Hey everyone, welcome back, and great to have that energy of our patient partner France. Just her story, very inspiring and really grounding us in the important work that we're doing at the front lines. Speaking of the front lines, it's great to introduce my friend and colleague James Kim, who's just down the road from me in Calgary. James is a family physician extraordinaire with special interests in many areas, but the connection between diabetes and MASLD is what brings him today. James, welcome and looking forward to your wisdom.
I don't know about the wisdom part, but well, thank you so much for having me. Okay, so I have bit of an unenviable task of introducing our guideline in 10 minutes. I don't know how I can do it, but I'll do it anyway. I've been very fortunate to be the co-lead author of Diabetes Canada's latest chapter, Diabetes and MASLD in Adults. So we'll talk about this and hopefully this will be an interest to you as well, especially coming from diabetes angle. So let's get started. So these are my disclosures. I've worked with the various companies dealing with diabetes and migraines predominantly. And so I'm not going to go through everything because this audience probably know most of these. Just gonna highlight the fact that why do we need the guideline from Diabetes Canada perspective on MASLD? Well, about 70% of our patients with type 2 diabetes actually have MASLD, and close to 40% of them have MASH, and about 15% of them have advanced fibrosis. What does that mean? In the last 10 patients who lives with type 2 diabetes that you have seen today or yesterday, at least one or two of them may have advanced liver fibrosis, and we are missing these patients. And type 2 diabetes is a major risk factor for liver fibrosis. Therefore, it was necessary for that the guidance on screening, diagnosing, and managing people living with MASLD and type 2 diabetes was necessary. So we kind of assembled the Avenger team, the A team, or the best team, whatever you want to call it, a superb team. So I was representing the family medicine and my co-lead author, Dr. Giada Sebastiani from hepatology, Dr. Alnir Ramji from hepatology, Dr. Harpreet Bajaj from endocrinology, Dr. Chantel Vermeer, who is a nutrition expert. And we also had a patient with a lived experience in form of Mr. David Leclerc. So in terms of the overview of the guidelines, so we started off with an introduction. So we are actually talking about the nomenclature change from NAFLD to MASLD and why that happened, epidemiology and the methodology of how we came about the guideline. Then we'll talk about the pathophysiology and the natural history of MASLD, screening for MASLD and liver fibrosis, which is probably the most important aspect of this guideline. Healthy behavioral interventions, and followed by the antihyperglycemic agents, in other words, diabetes medications, and also vascular protection medications that we can use for people with MASLD. So let's talk about the actual recommendations. So we read this out a few weeks ago in Halifax during Diabetes Canada conference. So for those of you who have attended that session, this may not be new to you, but hopefully this will be something interesting. So the recommendation number one, by the way, this is, if I'm not mistaken, this is the first guideline in Canada, specific the targeting for MASLD. And I was told that we are the first one in the world that actually has a dedicated chapter on MASLD from diabetes organization. So we're very proud of this. But anyway, I hope you feel very proud as a Canadians too. So the first recommendation is talking about the screening algorithms. So because we know through many researches that the endocrinologists and family doctors, many of them are not too familiar with MASLD. So we actually started off with a prelude to explain why the MASLD is a problem, an increased risk of cirrhosis, hepatocellular carcinoma, and premature mortality. Therefore, here is the recommendation number one. This first recommendation can be divided into three sections. So consider screening all individuals with prediabetes and type 2 diabetes with features of metabolic syndrome for MASLD-related liver fibrosis by basically using FIB-4 score to detect significant liver fibrosis, and that has received grade B level 2 evidence. Now, as you can see, we did not say that we should screen everyone for MASLD because of the prevalence of 70% of our population with type 2 diabetes having MASLD. We didn't think it was necessary to ask them to have screening process for MASLD, because the outcome is really determined predominantly by the liver fibrosis. So that's why we are going to ask people to screen for the liver fibrosis, not for the presence of MASLD. So that's the first part. The second, and this is a FIB-4 score, I'm sure you all know this, need 4 data points as age, AST, ALT, and platelet, and you get this magic number. And then the second part of this recommendation 1 talks about rather than only measuring ALT and AST, and that received a grade B level 2 evidence. And we know that many patients with MASLD and type 2 diabetes have normal liver enzymes. There's a study from Florida that actually showed that only 10% of the patients actually had, 10 to 15% of the patients with type 2 diabetes with MASLD actually had elevated liver enzymes. So we cannot rely on AST and ALT alone to decide whether a person has MASLD or MASLD-related fibrosis. And then the final, sorry, part of this recommendation 1 talks about the individuals requiring further investigations, follow-up, and referrals due to increased mortality and morbidity. And it says see figure number 6. So here is a figure number 6, and this is very similar to many of the other guidelines. So we said that in individuals with a low probability of a liver fibrosis, a FIB-4 score of less than 1.3, so right here, then just manage the metabolic syndrome in your clinic, whether it's in a primary care or an endocrinology clinic. They do not require any referrals, because the negative predictive value of the FIB-4 less than 1.3 of patient having advanced fibrosis, like 95%. So that's a pretty decent number. Good way to screen out the advanced liver fibrosis. And then the second part of this actually says that consider repeating screening the patients with a FIB-4 every 1 to 2 years, and they received a grade 4 level 4 evidence. Now, skipping 1B for now, so we're going to straight to 1C, says that individuals with a high probability of the liver fibrosis, a FIB-4 score greater than 2.67, then referral to hepatology is recommended, and grade C level 3 was given. And 1B is an interesting one, but I'm sure many of you are familiar with this type of recommendations. So we're saying that if the person has an intermediate probability of the liver fibrosis, a FIB-4 score between 1.3 to 2.67, then additional test is required, such as shear wave elastography or ELF, to further risk stratify the patient's health. And we gave the cutoff point, and if it's low, then just manage them in your clinic, just deal with their metabolic syndrome. However, if it's high, then the referral to the hepatology is recommended. Now, we do understand that there are places where they do not have these additional tests available. So for those people, we actually made another recommendations as part of 1B, saying that if you don't have those tests available or access to those tests, then referral to GI hepatology is recommended. And there are a number of guidelines around the world where they say that FIB-4 score greater than 1.3, just refer to hepatology. So we felt that we are in line with the science and then the guidelines from around the world. Recommendation 2 and 3 really focus on the lifestyle modification. So recommendation 2 talks about sustained reduction in body weight of 5 to 10% if possible. But if it's really possible, then try to aim for weight loss of 10% or more, as that can actually increase the chance of reversal of the fibrosis, and receive the grade B and level 2 evidence. And recommendation 3 really talks about incorporating the healthy behavior, whether it's a physical activity and the healthy dietary patterns that allows the greatest adherence over the long term is kind of what we are recommending. Recommendation number 4 talks about the anti-hypoglycemic agents. And as you can see, there are 2 agents that are being discussed in this particular recommendations. So in individuals with type 2 diabetes and biopsy-proven MASLD-related liver fibrosis, so that's F2 and F3, pioglitazone is recommended, grade A and level 1 evidence. We went back to the MERS team, who are the experts in the methodology and the critical appraisals, and they said that the pioglitazone data on MASLD on MASH is so good that you cannot give anything less than the highest recommendation that you can possibly give, and grade A and level 1. Now, there are people who are a bit uncomfortable prescribing pioglitazone. So in our text, we will talk about the pioglitazone and some of the things that you may want to watch out for. And then the second part of this recommendation talks about the subcutaneous semaglutide received grade D and level 4. Now, the reason why the semaglutide or subcutaneous semaglutide was given such a low grade was because the literature search actually ended on May of 2023, where the ESSENCE trial data was not available. As a matter of fact, we know that we only have the top-line result. We don't have the full results. Therefore, Diabetes Canada is very stringent when it comes to things like this. Therefore, it has received grade D level 4. I'm sure next year or a year after, when we revamp the guidelines, we may actually bump up their gradings a lot higher. Now, grade recommendation 5 talks about the vascular protections. We talked a lot, and we looked a lot into this. We looked at aspirin, we looked at ACE and ARBs and statins and so on. Some of the studies were very small to actually include into the guidelines. Some of the studies were actually neutral. So the only thing that we came up with was the people who's living with type 2 diabetes and MASLD should be treated with statin, not really to reverse the fibrosis. And I do understand that there is a small set of data with the rosuvastatin, but in general, we want to recommend a class of statins to further reduce their CV risk. Now, we actually made a highlight note saying that the medication statin should be continued in the absence of decompensated liver cirrhosis. And we looked at everywhere in Canadian guideline, and I believe that we're the first guideline that actually states that statin can be used all the way up to compensated liver cirrhosis. So that's that received a grade D level 4 evidence, and I believe that's in line with the US guideline as well. Final recommendation is on the surveillance. This is not really for the primary care, but really for the specialists, especially the ones who are working in the rural communities where they do need some guidance on this. In people living with the stage 4, so MASLD-related cirrhosis, routine surveillance is recommended using ultrasonography and serum alpha-fetoprotein every 6 months to detect for the hepatocellular carcinoma, or look for the clinically significant portal hypertension to identify individuals who may require upper GI endoscopy, to look for esophageal varices, and also to look for clinical signs and symptoms of hepatic decompensation to really optimize the liver-related outcomes. So I would like to have a special thank yous to Dr. Mark Swain and Dr. Kenneth Kuzi for being our external reviewers. Tracy Barnes, Diana Sheriff-Ali, and Donna Fitzpatrick-Lewis, and Jill Toffley, who's been absolutely fantastic from the admin support, and Dr. Felice Sink for his expertise in the graphics. Steering committees from the guideline, Dr. Peter Senior, Dr. Harpreet Bajaj, who really helped us to actually push this guideline and get to where we are. And Dr. George Bakris, who is actually a nephrologist. He's not with us any longer, but he's been an absolute inspiration and really guided us with our guidelines as well. So that's the guideline overview in 12 minutes. So I hope I did my job.
James, we knew you were up to the task, man. Well done. Well done. And a lot of reinforcement of points from our earlier speakers, and a very practical and useful approach to primary care.